Hello everyone, I am Dr. Singaram. Welcome to the discussion of recall questions in Pediatric section from NEET PG 2022 exam. We'll start with the first question. A 2-year-old male child presented with the complaints of passing loose stools with increased frequency. On examination, he is lethargic, not able to feed, skin turgor on pinching, the skin goes back very slowly. What is the severity of dehydration? This is a very standard question. We keep emphasizing about this during the lectures that assessment of dehydration in a child with diarrhea is always very important, and this question is exactly based on that. You can see complaints of passing loose stools with increased frequency is nothing but diarrhea, and the next two lines tells you about the level of dehydration in this particular child. Please remember, in a child with a diarrhea, the usual etiology for diarrhea is rotavirus, and if they ask you about the most common bacteria, then your answer would be E. coli, and that too enterotoxigenic E. coli. Overall, most common is a virus, which is rotavirus, but among the bacteria, it is enterotoxigenic E. coli. Now coming to the types of dehydration, remember there are three types: no dehydration, some dehydration, and severe dehydration. An important point to be noted is, in no dehydration, the child is active and alert. In some dehydration, the child has thirstiness as well as irritability. And in severe dehydration, the child is lethargic. Okay, right. And in every child with suspected dehydration, we have to do the skin pinch testing. And what we are going to assess is the time taken back for the skin to go back after releasing the skin after pinching. Remember, in no dehydration, it goes back very fast, meaning within 1 second it goes back. In some dehydration, it goes back slowly. It is less than 2 seconds. And in severe dehydration, it goes back very slow, which is more than 2 seconds. So these are the essential points about the assessment of dehydration in children with diarrhea. I'll take you back to the question where you can see that he is lethargic, which is a feature of severe dehydration. Not able to feed, again a feature of severe dehydration. Skin turgor on pinching the skin goes back very slowly. What is the meaning of very slowly? It means more than 2 seconds. So all this tells you very clearly that the answer for this question is that option C, which is severe dehydration. Okay. Please remember, in no dehydration and some dehydration, the fluid which we give is oral rehydration solution, whereas for severe dehydration, the fluid to be given is IV fluids, and the preferred IV fluid in diarrhea is Ringer lactate. Moving on to the next question. A 10-month-old female baby presented with jerky movements of the limbs towards the body. EEG shows hypsarrhythmia. The baby also has delay in attaining developmental milestone. Drug of choice for management of this condition. You see, this is a classical triad which you see that as infant, less than 1 year, that is 10 months is infant, presenting with jerky movements of the limbs, which is called as the infantile spasms. Along with that, the next is a hypsarrhythmia, which is a characteristic EEG finding, and third is delay in attaining the milestone. All this tells you about the possibility of West syndrome in this particular child. It's a very standard question about West syndrome, or it is also called as an infantile spasm. What is the drug of choice? It is going to be option B, which is ACTH. Remember, West syndrome is a condition characterized by a triad of infantile spasms, which is usually characterized by jerky movements of the limbs. What do you call it as? Jackknife seizures. Or it could be associated with spasms involving the neck, especially the flexors of the neck muscle. We call it as the salam spells. The second component of the triad is a typical EEG finding called hypsarrhythmia, which I'll put up the picture shortly. And third important finding is intellectual disability, which is low IQ. And along with that, the child also has developmental delay. You can see this characteristic EEG finding, which is the hypsarrhythmia. What are the findings you are noticing? The background itself is very haphazard or irregular, or what we call it as chaotic background. And in addition, you can see big spikes which are corresponding to seizure activity. So the complete description of Hips arrhythmia is high voltage spikes in a chaotic background. This is the description of Hips arrhythmia, which is a classical EEG finding in West syndrome. Remember, the drug of choice for treatment in West syndrome is injection ACTH. That is what the question was about. The second line drug is vigabatrin. At this point, you should also remember that there is a neurocutaneous syndrome called as tuberous sclerosis. If tuberous sclerosis is associated with West syndrome, then the first line medication or the drug of choice becomes vigabatrin. So remember, in general, for West syndrome, the drug of choice is ACTH, but in tuberous sclerosis associated West syndrome, it is vigabatrin, which is the drug of choice. Moving on to the next question. A newborn 4-day-old baby was found to have TSH value of more than 100 milli-international units per liter. Ultrasound shows eutopic thyroid. What will be the next investigation? Please remember, this is a very clear-cut case of hypothyroidism because of the finding that the TSH level is very high. Please remember this. TSH more than 20 itself is considered as significant in a newborn, and more than 100 is almost sure that it's a case of hypothyroidism. And we all know that all newborn babies should be screened for congenital hypothyroidism after birth. Okay, right. Now this question is about what are the investigations for hypothyroidism. Okay, one investigation already done is ultrasound. What is the next investigation? Okay, you have options like urine iodine excretion, radionuclide scanning. Option C is serum TRAB, which is TSH receptor antibody estimation, and anti-TPO, that is anti-thyroid peroxidase antibodies estimation. What is the answer? It is radionuclide scan. The usual radionuclide scan which we perform in congenital hypothyroidism cases is iodine 123. The next radionuclide scan is technetium 99 scan. The preferred is always iodine 123, which is a radionuclide scan preferred in, I will do that again, the preferred, okay? Yeah. The preferred radionuclide scan is always iodine 123 scanning, okay? Right. Now this is a diagnostic approach for babies with congenital hypothyroidism, okay? I'll start with the approach based on the thyroid scanning, wherein you can have three things under the thyroid scan. One is no uptake, next one is ectopic uptake, which is suggestive of ectopic thyroid gland, and third is increased uptake. Whenever there is increased uptake, you have to suspect conditions like dysharmonogenesis as well as iodine deficiency situations. Ectopic uptake, as I already told you, it is ectopic thyroid gland. If it is no uptake, it can be the other possibilities, including thyroid dysgenesis. So for this, you have to go for the next investigation, which is ultrasound thyroid. Okay, ultrasound thyroid may not show the presence of thyroid gland itself. In that case, it is agenesis of the thyroid, or it may show a small thyroid gland which is hypoplasia of the thyroid, or it may show a normal thyroid gland itself. Okay, now if it is a normal thyroid gland, then you have to do the next set of investigation, which is estimation of TSH receptor antibodies. If the TSH receptor antibodies are positive, it means it is a maternal passage of TSH receptor antibodies in that particular baby. Suppose TSH receptor antibodies are not present, then it may be a case of a defect in the thyroid biosynthesis, which could either be a iodide trapping defect, or it could be a TSH receptor defect. These are the diagnostic possibilities based on the investigations which we do in a case of congenital hypothyroidism. So don't forget, the two important investigations are, one is the thyroid scanning, the next one is the ultrasound thyroid. When we talk about the thyroid scan, it is radionuclide scan of the thyroid, usually using iodine 123. Moving on to the next question. The next question is, a neonate has not passed urine in the last 24 hours since birth. Next step in the management. So the baby is now 24 hours and still not passed urine. Remember, according to the standard text, 17% of the babies, they pass urine in the delivery room. 90% of the babies, they pass urine in the first 24 hours. And 99% of the babies, they pass urine in the first 48 hours. So that means a baby not passing urine is a cause of concern only if it is after 48 hours. Okay. In this question, it is only 24 hours old baby which has not passed urine. It is usually not a cause of concern. So among the options given, the answer has to be option A, which is continuation of breastfeeding and observe the baby. That's all. So now comes the question, when should I take the next step? That is admitting the baby in ICU for further evaluation. It is any baby who has not passed urine at all for more than 48 hours after birth, then I have to admit the child in the ICU. Second, after day one, if the urine output is less than 1 ml per kg per hour, then also I need to admit the child in the ICU and evaluate. In the ICU, what I am going to do is something called as a fluid challenge. This involves administration of 10 ml per kg of normal saline over 20 minutes. And after 20 minutes, I have to look for the urine output. If the urine output increases to more than 1 ml per kg per hour, then it is a pre-renal type of acute kidney injury. If after fluid challenge also the urine output is still less than 1 ml per kg per hour, it is a case of intrinsic renal failure or intrinsic AKI. So some problem or a parenchymal problem in the kidney has to be suspected. So that is about the discussion of this particular question. Because this baby is only 24 hours old, my answer would be continue breastfeeding and observe. A 2-year-old child presented with acute onset breathing difficulty while playing. There is no previous history of similar complaints. Chest X-ray shows unilateral hyperinflation of the right lungs. What is the true option? First, let us understand the question. 2-year-old child with sudden onset of a breathing difficulty. Can you see acute onset of breathing difficulty and no previous complaints also. So this situation you have to suspect about foreign body obstruction. Foreign body obstruction. And you can see the chest X-ray finding is given with relation to lungs. Okay, right lungs, that too. So I would suspect it is a lower airway foreign body. Okay, lower airway foreign body. Now let us try to explain this unilateral hyperinflation. For that, please understand that foreign body can either cause a complete obstruction of the airways or partial obstruction of the lower airways. So think like this. This is the trachea and the bronchus, and a foreign body is causing complete obstruction of this bronchus. Imagine this is the bronchus, B for bronchus, and it is causing complete obstruction. Now this is a normal lung field for reference. Now what is going to happen? Through this complete obstruction, the air will not be able to pass beyond. So what would happen to the size of the lung field? It would become collapsed or smaller in size like this. So complete obstruction will be associated with collapse of that particular lung fields or small size of that particular lung fields. Whereas if it is a partial obstruction, think like this. This is again the trachea and the bronchus, and you have a foreign body which is partially obstructing the airway. Think like this. Now this will create something called as a ball valve effect. Meaning during inspiration, the air can still pass through that because it's a partial obstruction. Okay. But during expiration, the air which is supposed to come out will not be able to come out because of the ball valve effect. Or in other words, what will happen? The air will become trapped inside the lung fields. So what would happen to the size of the lung fields? It would become huge in size, and this is what we call it as a hyperinflation. Okay, yes. So now going back to the question, here it says there is a unilateral hyperinflation of the right lung. So probably this foreign body should have caused partial obstruction in that area. Okay. So among the options, you can see which should be the answer. Focal area, focal hyperinflated area with no or decreased breath sounds will be suggestive of a foreign body. Because you look at the other options, flexible bronchoscopy is used for removal. No, it is a rigid bronchoscopy which is used for the removal of foreign body obstruction. In complete obstruction, bowel wall mechanism causes hyperinflation. No, bowel wall mechanism causes hyperinflation, but it is not for complete obstruction. It is for partial obstruction. Child has laryngotracheobronchitis. Again, a obviously wrong answer because it's a foreign body obstruction of the airway. So the answer has to be option D. Can you see that focal hyperinflated area is due to foreign body? I have explained that in that previous pictures. And obviously, whenever there's a foreign body which is blocking the airway, you will have no or absent or decreased breath sounds in that area. That is also true. So the complete correct option and the answer for the question is option D. Moving on to the next question. A 2-month-old infant of a HIV positive mother presents with diarrhea. What is the next best step in the management? Test the stool for Giardia antibody test for HIV, dried blood spot sample for HIV PCR, and stop the breastfeeds. Let us look at the options one by one. This is a HIV positive mother and her baby is presenting with diarrhea. Please remember that testing the stool for Giardia is not always the best step in the management, because let us look at the options one by one. The first option is testing the stool for Giardia. That means we are sure that in this particular child, giardiasis is a diagnosis. Are we sure? Not at all, because giardiasis can be a possible cause of diarrhea in a baby born to HIV positive mother, but it is not always the most common cause. In fact, in a baby who is immunocompromised and is having HIV positivity, probably the common cause of diarrhea is other organisms like Cryptosporidium and not giardiasis. So testing for giardia at this time may not be the best option. So that option is wrong. Next option, antibody test for HIV. Remember, antibody test for HIV like ELISA is a standard test by which we detect HIV infection. But this is a 2-month-old child. Very important. What would have happened? The maternal antibodies could be in the baby's circulation, and that itself could give a positivity for antibody testing. Okay. We cannot say at this time itself that antibody test positive means ELISA for this child, because it could be probably a maternal antibody as well. And please remember this point, the maternal antibodies can persist in the baby circulation for up to 18 months. So that is why the antibody testing for HIV infection in a small child till the age of 18 months is never advised. That is a point to be noted. Look at the option C, dried spot sample for HIV PCR. This is the correct option, and this is the standard way by which we establish the diagnosis of HIV infection in a small child. It is HIV PCR testing. You can either do the HIV RNA PCR or HIV DNA PCR. Usually HIV RNA PCRs are more sensitive and are the preferred test for diagnosis. Stop breastfeed. It is not always an option in the Indian scenarios, because some are not affordable for the formula milk, and that may lead to malnutrition in the child also. So that is why stop breastfeeding is not at all a good option, okay, especially in the setting of Indian population. Okay, right. 11-month-old child presented with incessant crying. On examination, a tender mass per abdomen was palpable in the right lumbar region. Barium enema imaging is shown below. What is the diagnosis? You can see it's a small child, 11-month-old child, with a classical features like incessant crying. Incessant crying is equivalent to severe abdominal pain in a small child. A child cannot complain of the pain, so the child instead has incessant crying. So it may be equivalent of a severe abdominal pain in the child, number one. Number two, a very classical finding that there is a mass per abdomen, but the region is very characteristic, light lumbar region. And your diagnosis is going to come from the barium enema picture, which shows a clear cutoff at this area, which is called as a claw sign, or it is also called as a coiled spring sign. And presence of this sign is very, very characteristic of option A, which is intussusception in this particular child. Please remember, intussusception is an important condition usually occurring in young children, and intussusception is characterized by, as you can see from the picture, it is telescoping of one part of the intestine into the other. The most common location is ileocecal. And usually intussusception is noted in the age group of 8 to 10 months. Okay, and the characteristic features of this particular condition would include colic. Colic is the intermittent severe abdominal pain. A small child may not complain of the abdominal pain. Instead, the child can have incessant cry as given in the question. Next is the presence of current jelly stools, and third is a typical mass. This is a tender mass, painful mass, palpable in the right upper quadrant of the abdomen, and the classical shape of the mass is a banana shaped mass or a sausage shaped mass. That is very, very classical of intussusception. Please note that in this particular question, the barium enema picture is given. However, remember, the usual investigation which we do is ultrasound, which is a very, very sensitive investigation, and ultrasound is not only helping in the diagnosis, it can also help in the treatment or therapeutic. You can do the hydrostatic reduction of that intussusception with the help of ultrasound guidance itself. So that is why ultrasound is not only a diagnostic investigation, it is also a therapeutic modality in intussusception. And that is the answer for this particular question. Moving on to the next question, it was a spotter type question where they have put up this anomaly and asked you to identify what it is. You can see that red fleshy mass which is getting exposed outside below the umbilicus region. What is this red fleshy mass? It is nothing but the bladder. So it is exposed bladder to the outside. What do you call it as? Option A, which is bladder exstrophy. Okay, it is not going to be the other options like gastroschisis, omphalocele and patent vital intestinal drug. These are some pictures of the same. You can see that in omphalocele, the contents of the intestines are coming out and it is covered by the omental sac. Whereas in gastroschisis, the intestines are exposed outside without any covering. Okay, so they won't be the answers for this particular question. The answer was bladder exostrophy. Few points about bladder exostrophy. It is also called as ectopia vesicae. Vesicae means bladder, ectopia means abnormal location. That's why it's called ectopia vesicae. This is a condition more common in males. Male-female ratio is 2:1. The characteristic features other than the exposed bladder is that the umbilicus is displayed downwards and the pubic rami are widely separated. And because of the wide separation of the pubic rami, these children have a characteristic broad-based gait. Okay, other notable associations include epispadias. They also have cryptorchidism, undescended testis. An important long-term risk of this bladder exstrophy is increased risk of bladder cancer, especially adenocarcinoma of the bladder. These are the salient points about bladder exstrophy which is asked in this particular question. Moving on to the next question. A 10-year-old male child with bloating of abdomen, steatorrhea, reduced height and weight. He was found to be HLA-DQ2 positive. Which of the following will you advise the child to avoid? High fiber diet, lactose-free diet, low carbohydrate diet or a gluten-free diet? You see here, the characteristic features in this child are bloating of the abdomen, which may not be very suggestive of any particular diagnosis, but steatorrhea, it is suggestive of malabsorption, especially malabsorption of fat. We all know that. Reduced height and weight. So probably this child is having a chronic problem involving the abdomen like a chronic diarrhea, and because of that the child is also having reduced height and weight. We call this as failure to thrive. Failure to thrive. Even till this point, there are so many diagnostic possibilities, but you look at the very next line of the question, a genetic predisposition in the form of HLA-DQ2. HLA-DQ2 positivity with a condition like diarrhea or malabsorption always points to the possibility of celiac disease. We all know that celiac disease is a type of gluten hypersensitivity where there is an allergic manifestation to gluten in the diet. So that is why the answer for this question has to be gluten-free diet. In fact, it is lifelong gluten-free diet which is advised for patients with celiac disease. Celiac disease is such an important topic. You should know some salient points about the same. As I said before, it is a gluten hypersensitivity and it is usually associated with exposure to foods which are remembered as bro. What is that? Barley, rye, oat and wheat. And please remember that celiac disease results from the exposure to gluten in the diet as well as with genetic predisposition like HLA-DQ2. This was given in the question. Another HLA association is HLA-DQ8. Okay, and the diagnostic investigation for celiac disease is nothing but small intestinal biopsy, where you will see the characteristic features like atrophy of the villus along with increased space between the villi called as crypt hyperplasia. Along with that, inflammatory cells will be present in the intestinal villi. Okay, all these are characteristic in the small intestinal biopsy. And celiac disease is also characterized by the presence of antibodies, and the best antibody which can help in the diagnosis of celiac disease is anti-EMA antibody. What is EMA? It is anti-endomysial antibody, which is the best investigation among the antibodies in case of celiac disease. Moving on to the next question. A 11-year-old child had fever and sore throat 3 weeks back and now presents with fever, arthralgia and raised ESR. Heart evaluation is normal. How long should he receive penicillin prophylaxis? Please see this question, a typical age group, 11 years, something like a school-going child. Along with that, fever and sore throat history of 3 weeks back and now present with fever, arthralgia, raised ESR. What will you think of following a sore throat and now having fever and arthralgia? Yes, it's an acute rheumatic fever. Acute rheumatic fever. Fortunately, in this child, at present, the heart evaluation is normal. How long should he receive penicillin prophylaxis? We all know that acute rheumatic fever is a post-streptococcal condition, and future attacks of streptococcal infection again can precipitate an episode of rheumatic fever. But please remember, during recurrent attacks, heart is severely damaged. That is why always we need to give prophylaxis for these children with acute rheumatic fever to prevent any further attacks in future. Now the question is, how long should he receive prophylaxis? Please remember, the prophylaxis duration depends on the involvement of the heart. If there is no carditis, the prophylaxis is recommended for next 5 years or till the age of 18 years, whichever is longer. If the child has carditis, it is recommended for the next 10 years or till the age of 25 years, again, whichever is longer. Suppose the person has established RHD, that is rheumatic heart disease, or underwent a surgery like valve repair or replacement, ideally it is lifelong prophylaxis. Few texts will say that up to the age of 40 years it is recommended, but ideally it is lifelong prophylaxis which is recommended. Now coming back to the question, our question says that at present the heart evaluation is normal. That means he has no evidence of carditis. So what should be the answer? It should be for the next 5 years or till 18 years of age, whichever is longer. Option A is the correct answer. Regarding the drugs for prophylaxis, the commonly used drug is the penicillin, which is benzathine penicillin or penicillin G. It is usually given as an injection and the dose depends on the weight of the child. If the child is more than 30 kg, it is 12 lakh international units every 3 weeks. And if the child is less than 30 kg, it is 6 lakh international units every 2 weeks. As an alternative to the injectable penicillin, what we are using nowadays is oral penicillin V, which is usually given in the dose of 250 mg twice a day. Suppose the patient is allergic to penicillin, we will use erythromycin. Usually erythromycin is given in the dose of again 250 mg twice a day. So these are the drugs for prophylaxis. Remember, the type of prophylaxis in acute rheumatic fever is secondary prophylaxis. The next question is about a 10-year-old child presenting with edema and massive proteinuria. A diagnosis of minimal change disease was made. Which of the following is true about this condition? Remember, edema, anasarca and massive proteinuria are all characteristic features of nephrotic syndrome, and in that the diagnosis itself is already given, which is minimal change disease. In fact, minimal change disease is the most common condition associated with nephrotic syndrome in children. The question is, which is true about this condition? Light microscopy shows effacement of podocyte. Remember, effacement of podocyte is a feature of minimal change disease. However, not on light microscopy you will be able to see. It would be seen only on electron microscopy. So that is not the answer. Next, good response to steroid. That is the answer for the question. In fact, all minimal change disease condition usually show an excellent response to steroids, and that is the answer for the question. Most common in adults? No, it is a type of nephrotic syndrome which is common in children. Non-selective proteinuria is again a wrong option because they have more of albumin excretion in the urine or more of a selective proteinuria. So all these are wrong options. The correct answer is option B. So nephrotic syndrome, according to the latest guidelines, the criteria is presence of significant proteinuria along with hypoalbuminemia or edema. Please remember, the criteria for significant proteinuria is more than 40 mg per meter square per hour of protein excretion in the urine. This is something which you should clearly know about. What is the criteria for nephrotic range proteinuria in children? That is also called as significant proteinuria. Okay, and as we discussed, the most common condition causing nephrotic syndrome is MCD, minimal change disease. Okay, please remember that minimal change disease is a diagnosis made pathologically, but clinically, how can we say that it is a case of minimal change disease? One is the age of the child. Typically, it occurs in the age group of 2 to 6 years. And second important hallmark feature is response to steroid. They show an excellent response to steroids. And the usual steroids which is used for this condition is prednisolone. And the duration of steroid treatment is 12 weeks. It is typically given as 6 weeks of daily steroids and 6 weeks of alternate day steroids. So that's about this particular question. Let's move on to the next question. A 5-year-old male child has difficulty in walking and getting up from a squatting position. Muscle biopsy was done and the picture is given. Which of the following is true about this particular condition? Remember, when the muscle biopsy picture is given and there is a difficulty in walking and a male child is given in the question, you always think about a muscle disorder, primarily a muscular dystrophy in children. Now, getting up from the squatting position, difficulty in getting up from the squatting position tells you that there is a proximal muscle weakness. We are talking about the proximal muscles in the hip region are having a weakness. Again, proximal muscle weakness is also a feature of muscular dystrophies or muscle disorders in children. Now let us look at the muscle biopsy finding. What you can see is that the size of the muscle fibers are not consistent. There is different shape of the muscle fibers which you can notice, and also there is evidence of these necrotic muscle fibers. Along with that, you can also see the connective tissue in between the muscle fibers is increased. What we call it as endomysial connective tissue proliferation is noted. And these are all very classical findings of the most common muscular dystrophy, which is DMD. What is that? It is Duchenne muscular dystrophy. And that is the diagnosis for this particular question. So let us look at the options related to this question. Death occurs by third decade. Is it true? That is the correct statement about Duchenne muscular dystrophy, and the answer for this question. Usually Duchenne muscular dystrophy patient when they become teenagers or by 20 to 29 years or around that third decade, they usually die. And that's a true statement. Previous history of viral prodrome is present, not at all. It is not a post-viral condition and all, so that option is wrong. It's a mitochondrial storage disorder. No, it's a muscular dystrophy disorder. It's an inherited condition, so it's not a mitochondrial storage disorder. Early treatment has excellent prognosis. Not at all. It is not a curable condition. Even though steroids are found to decrease the progression of the disease, still it is a progressive disease and finally causes death, and no treatment is curative for this particular condition. So that is also a wrong option. So the answer is option A. Now please remember, these are the texts which are taken from Nelson textbook of Pediatric, where it clearly mentioned that death in boys with Duchenne muscular dystrophy occurs in the late teens to 20s. That means in the third decade, they usually die. And the cause of death is a combination of respiratory problems like respiratory failure, as well as cardiac problems like intractable heart failure. These are the two usual conditions associated with death in a child with Duchenne muscular dystrophy. To explain that findings only, I'll do that again. Okay. To explain the findings in Duchenne muscular dystrophy, this muscle biopsy picture is taken. The first is a normal muscle biopsy picture where you can see a consistent size of the muscle fibers, whereas the next picture is for DMD or Duchenne muscular dystrophy, where you can see irregular shape of the muscle fibers, and also you can see evidence of necrosis happening in the muscle fibers. These are all very, very characteristic of Duchenne muscular dystrophy on the muscle biopsy. DMD as such is the most common hereditary neuromuscular disorder, and the most common mode of inheritance is X-linked recessive mode of inheritance. Okay, right? And the basic defect is in the dystrophin gene defect. Please remember, the characteristic type of dystrophin gene defect is a frame shift mutation. The characteristic features, clinical features of Duchenne muscular dystrophy is 1. Proximal muscle weakness. And because of the proximal muscle weakness, they have delayed walking. They have this characteristic waddling gait, as well as they have the positive Gover sign, okay, which is a sign elicited on asking the patient with Duchenne muscular dystrophy to get up from the sitting position. Okay. Please remember, Gover sign is not diagnostic of Duchenne muscular dystrophy. In any condition where you have proximal muscle weakness, like in juvenile dermatomyositis, there also you have proximal muscle weakness, and there also Gover sign is positive. And third important feature is pseudohypertrophy. This pseudohypertrophy is due to deposition of fibrous tissue and fatty tissue in the region of calf muscle area. So pseudohypertrophy characteristically noted in the calf muscles is again a characteristic finding in case of Duchenne muscular dystrophy. And finally, what happened? They will have progressive muscular problems leading to loss of ambulation around the age of 10 to 14 years. Or in other words, around the age of 10 to 14 years, they become wheelchair dependent. These are the characteristic features of Duchenne muscular dystrophy that one should know about. The next question, an 8-year-old male child presented with palpable purpura over the lower limbs and also complaints of arthralgia and abdominal pain. There was a preceding history of upper respiratory infection. Which of the following drug is useful in the management? Please remember that when you have a child presenting with a classical description of palpable purpura, abdominal pain, as well as joint pain or arthralgia, you should strongly consider the possibility of HSP. Henoch-Schfnlein purpura, which is IgA vasculitis. It is one of the common vasculitis in childhood, and it is a small vessel vasculitis. Now this question is about drug useful in the treatment of Henoch-Schfnlein purpura. When you talk about Henoch-Schfnlein purpura treatment, remember, most cases are self-limiting, and all that is required is supportive treatment. Supportive treatment usually includes good nutrition, good hydration, as well as pain relief with analgesics. That is all that is required for the management of HSP. However, if a drug is going to be helpful, the commonly used drug is a steroid, and the role of steroid is not for all cases, only if there is a significant gastrointestinal involvement or any life-threatening manifestation, then you are supposed to use the steroid. So suppose child presents with intractable abdominal pain or other GI manifestations which is very severe, then you can use steroids. Also, steroids can also reduce the intensity of abdominal and joint pain. So again, severe manifestations of disease only requires the use of steroid. In this particular question, you can see 4 options given. Out of that, steroids are the ones which can be helpful in the usual management, and don't forget, only in severe cases of HSP, steroids are required in the management. This is the diagnostic criteria for Henoch-Schfnlein purpura. Please remember that the most essential criteria is palpable purpura. Usually palpable purpura is noted in the lower limbs, and the reason for purpura is vasculitis and not thrombocytopenia. Or in other words, the platelet count is normal in case of Henoch-Schfnlein purpura. This is a very essential part of diagnosis, presence of palpable purpura. Along with that, you should have one or more of the following manifestations, which include abdominal pain, which is a type of diffuse acute colicky pain in the abdomen, and usually it is after food intake or postprandial abdominal pain. Next, they can have arthritis or arthralgia. Third, biopsy. Usually the skin biopsy is taken and biopsy demonstrates IgA deposition. And finally, some cases can also have renal involvement in the form of proteinuria, hematuria or red cell cast. Please remember, palpable purpura along with any one of the other 4 features would be making to the criteria of Henoch-Schfnlein purpura. So that is about the discussion of this question, and with that I am ending the discussion of NEET PG 2022 questions asked in the section of Pediatrics. Thank you.